Hello, good morning. I'm
Good
Dr.
morning.
Sharif. Good morning. I'm Dr. Sharif. I'm a cardiologist and I will be your physician today. What's your name?
Mrs. Najat.
How old are you, Najat?
I am 27 years old.
Okay. Are you married or do you have kids?
Yes, I'm married since 3 years, but I didn't have any kids till now.
Okay. Do you smoke?
No, never. I didn't smoke.
Okay. Do you have medical history like hypertension, diabetes, dyslipidemia?
I previously diagnosed as hypertension since 1 year, but I didn't use any medication since that time.
Okay. Um, and do you have some family history? Uh, cardiac disease history in your family.
No, absolutely. Nobody in my family has any cardiac problem.
Okay. What's your complaint?
See, doctor, I am feeling of difficulty of taking my breath. This is a
Okay.
new symptom for me since about 2 days.
Okay.
Uh,
Do you have other complaints with this shortness of breath?
I have the symptom. This symptom started before 2 days gradually. Then lastly, it happened at rest. At the beginning, it started with exercise, and I noticed when uh, I am in a flat position, the dyspnea also increased. This for me, this is new symptoms. It is different from previous symptoms, which was happened to me before 1 year.
Okay.
Uh, I was feeling of lightheadedness. I felt unsteadiness, floating sensation in my head since 1 year, but also increased last 2 days. Um, that is all till now.
Okay. And before these 2 days, did you have some other complaints?
Yeah, I feel a sensation of headache, severe headache. Since 1 year, also increased last 2 days. This is
Okay.
making me so afraid. This pain was happened in my back of my head
Okay.
and in the neck. Yeah, sometimes associated with nausea, with vomiting, and also occasionally associated with the blurring of vision. Also, I felt a sensation of weakness in the
Okay.
upper limbs, in the lower limbs, since 1 year also, but increased last 2 days. I felt, doctor, exhaustion, uh, easy fatigability with
Okay.
simple exercise is affecting my life. I couldn't do simple daily activity in my home, which increased lastly in last 2 days. So I am afraid what's happened to me now. What's new now?
Um, uh, did you have did you take some medication?
Uh, no, I sought really I sought medical advice
Mm-hmm.
in the last year about twice times. The doctor told me when he measured my blood pressure, he told me the reading of blood pressure was high. He advised me to do some investigations, to
Okay.
take medication. But I refuse to take medication. I am young to for hypertension. I thought my dad, my mom are not hypertensive, so I refuse to take this medication.
Okay. Um, and Do you had some pregnancies before?
No, no, absolutely no. I tried to get pregnancy, but failed.
You are not using contraceptive pills.
No, no, I want to get pregnancy, so I'm not
Okay.
using contraceptive.
Okay, so we are going to do some investigations, blood test, examination, and EKG, and you are going to find what's happening, inshallah. Okay?
Inshallah. Okay.
Okay. So it was about a 27 years old female patient, married with no special habits. For her cardiovascular risk factor, she's non-smoker, hypertension since 1 year without any treatment, non-personal or familiar history of cardiac disease or sudden cardiac death. Chief complaint, dyspnea and orthopnea since 2 days, dizziness and headache since 1 year. On the physical examination, the patient was conscious, alert, oriented to time, place, and persons, with a body mass index at 24 kilogram per meter square. Blood pressure was 18 by 180 by 95. Heart rate at 110. Fever with a temperature at 38.2, respiratory rate at 24 cycle per minute, saturation 91%, and with impalpable radial and brachial bilateral pulses. For examination of head and neck, the examination of the head and neck was normal. The jugular venous pressure was normal. At chest examination, there were basal bilateral crackles. The abdomen was soft, lax, with no palpable masses or tenderness. For the central nervous system, no focal or systemic neurological defect. For the heart regular sounds and without murmur. On the ECG, she has just sinus tachycardia without any other problems. For the lab tests, hemoglobin level at 11.8, normal renal function, negative troponin, blood cells at 4,160, positive CRP at 24, normal potassium and calcium level, normal thyroid lab tests, and anti-proBNP at 3,000. At the TTE, non-dilated left ventricle with left ventricular hypertrophy and preserved systolic function, diastolic dysfunction, no wall motion abnormalities, mild aortic regurgitation, normal right ventricular systolic function, and pulmonary artery systolic pressure at 38. Patient received oxygenotherapy plus IV diuretics and dicardipine at the emergency department, and after 4 hours, she has a good saturation with heart rate at 90 and blood pressure at 140 by 80. So let's go to the MCQs. Given these parameters, what diagnostic do you think of? Heart failure with preserved ejection fraction, cardiac amyloidosis, or cardiac sarcoidosis?
Yes. What do you think? I think
I would
cardiac
say
yes, completely.
CFS.
Should we start the discussion?
Yes, think fair share.
Of course. Okay, definitely. You are talking about if you put the subject in a nutshell. You think? Could you please tell me the most important findings? To my knowledge, there is basal crackles. There is, I think, hypertension as well. There are the echo maybe it's non-significant, and maybe the I don't think there is echo findings of amyloidosis. I don't think. How you think? Yes, let us come back. This is a female patient, and she's complaining of dyspnea and orthopnea. with hypertension as well.
She's
doesn't have
27.
27 years old. Next, please. And the next is there is impalpable radial. There is hypertensive, 180/95, and she's conscious. Her index is 24, body mass index. So we can see that she's not obese.
Yes.
24, this means she's not obese. Heart rate is a little sinus tachycardia, a little bit feverish. And the heart tachycardia is coincident with the fever, respiratory rate as well. Impalpable radial and brachial and radial pulsations. Next, please. Next, please. So, what do you think will be about the echo? I don't think there is significant changes in the echo. Yes,
there was a diastolic dysfunction with a mild
which is
outpatient
no, it is not diastolic dysfunction for an age of 27. This is not normal. But actually, there is no wall motion abnormality. There is the pulmonary pressure is a little bit high, so the echocardiography maybe shows that there is diastolic dysfunction with pulmonary hypertension. Okay, but there is what about you said that the amyloidosis, does it go with amyloidosis? What will be the echo findings in a patient with amyloidosis?
Enlargement
if you want
of
us
the
to,
atria.
yeah,
A
Pericardial
typical
effusion.
echocardiogram, yes, in amyloidosis, there is biventricular wall thickening with normal cavity size and biatrial enlargement. And this is
it was not negative for her.
with the absence of the radial pulse. I went to another diagnosis, but when with the echo, with the echo finding, the diastolic dysfunction, the examination, bilateral crackles, the NT-proBNP levels, that would be the HFpEF. But
yes,
I can't think of the same pathology for that would give us heart failure with preserved ejection fraction and absence of radial pulse, because hypertension, she's only 27 years old. I don't think that explains the diastolic dysfunction that she has and the 3,000 NT-proBNP levels. It's HFpEF for sure, I think, and another pathology could explain that I have in my head, could explain the bilateral, the absence of bilateral pulses, but I don't know if because I'm thinking of the Takayashu syndrome. I'm not sure.
I agree.
Yes, I'm not sure that it could give the HFpEF. We'll see.
Yes, we will see.
Yes,
Let
we'll
me
see,
continue
because
the MCQs.
so maybe I think that cardiac amyloidosis is not there. Sarcoidosis, we're not sure of that, but maybe we do have heart failure with preserved ejection fraction, and
yes, right,
maybe sarcoidosis because there is some element of hypertension, and so but
So-
but young, I do my comment that the young and very young patients with heart failure with preserved ejection fraction display the similar adverse cardiac remodeling compared with their older counterparts.
yes.
This is a very important.
She's
Yes.
too young, and I think if in the items we had something regarding her gynecological situation, does she have kids? Is it postpartum? I would have thought of Meadows cardiomyopathy for a person that has 27 years old and that has heart failure, but I think that's not the context right now.
Yes. So, it was a HFpEF according to H2FPEF score. She hasn't obesity, but she has hypertension. She has no atrial fibrillation, but she has pulmonary hypertension with feeling pleasure. So it's a score of 3. We are in the middle here. And we have a positive NT-proBNP levels, so the diagnosis of HFpEF is positive. Question 2. For this patient, what is the risk factor of the development of heart failure with preserved ejection fraction? Is it hypertension, anemia, or young age, according to the European recommendations?
Okay, can you thank PearShare now and ask your team members?
Yes. I'm asking the team members.
Where are they?
Yes.
Can you open your cameras, everybody, so you can see it, please?
Do you know
A.
the risk factors of the development of heart failure with preserved ejection fraction?
A.
Okay. So it's A. And this is the table of the 2021 ESC recommendation with the risk factors of the development of heart failure and potential corrective actions. We have sedentary habits, cigarette smoking, obesity, excessive alcohol intake, influenza, some microbes, cardiotoxicity drugs, chest radiation, hypertension, like for our patient, dyslipidemia, diabetes, and coronary artery disease.
So maybe the hypertension will be one of the important,
Yeah.
yes, number one, I think. And of course, young age is not a risk factor because it's
Yes.
usually with the older age.
Right.
But the person the person is obese now? You said
No,
No, it is not
no.
obese because
24.
it's 24 body mass index. But I have
Yes.
a comment upon
Okay.
that. You
Okay.
don't. You should comment upon the waist circumference, not the body mass index. But of course, the body mass index is important, and when we say the body mass index, we should consider also the waist circumference for this patient and waist hip ratio as well.
Okay. So question 3, at this stage, which test or imagery will you perform? Renal echography, chest MRI, or myocardial scintigraphy? We are in front of patient with at 27
I would
years
go.
and hypertension.
I would go with the renal echography.
Yes.
Could you please,
Because the patient is young, she has hypertension, and she has the bilateral absence of the pulses. So I might be thinking of renal stenosis.
I think
Okay.
so. Yes, I agree. I agree with that because she's
Okay,
a young,
it's right.
and also she's a female. She's a female as well, and maybe the renal artery problem could be more or less
Dysplasia,
common in
yes.
the female. Yes.
Yeah.
could you share your screen?
So, right. According to the European recommendation of 2018, for young adults between 19 and 40 years old, we have to think about renal parenchyma disease, fibromuscular dysplasia, and undiagnosed monogenic disorders. So for these etiologies, we have to do a renal and a Doppler of the renal arteries imagery. So the renal Doppler was sorry.
Just question, Noor, what about the level of kalemia of this patient?
Normal. Sorry. She has a normal potassium and calcium levels.
Okay. And when you did the test, she took already any antihypertensive treatment?
No, she was diagnosed hypertensive since 1 year, but she refuses to take any medications because she's thinking she's too young to have medications for hypertension.
Okay.
Yes.
Okay. On the renal ecography, she had normal size of kidneys, no normal parenchymal kidneys with stenosis of the left renal artery and thickening of the abdominal aorta. So we are going to the fourth question. What is the most likely diagnosis now? Is it Takayasu arteritis, fibromuscular dysplasia, or Marfan disease?
So they have an answer. Could be fibromuscular dysplasia. I think could
Yes.
be one of the important
It's probably.
findings. Marfan syndrome, of course, you should have other criteria, and this lady should be tall, should have some other problems. She may have some dilated aortic root, and so maybe Takayasu arthritis, of course, have other criteria. So I do think in a young female, age 27 years, maybe fibromuscular dysplasia will be.
But would it explain the absence of the radial pulse, the fibromuscular dysplasia? Because we have stenosis not only in the renal artery, but also theoretically
In the
upper limbs, in both upper limbs.
Yes. So she's hypertensive. She's hypertensive as well. So I think it's a non-atherosclerotic, non-inflammatory disease of the blood vessels that causes abnormal growth within the wall of an artery.
Mm-hmm.
And it's maybe it's present in this lady in nearly every arterial bed in the body for this lady. And the most commonly detected affected is the renal and the carotid artery, as far as I know. So
and we have slightly elevated CRP levels, if I remember.
Yes, it's an inflammation, I think
Yeah.
so, and maybe that it maybe affects the medium-sized arteries in the body, and maybe it doesn't affect the large arteries. So maybe it doesn't affect the aorta or something, just causes the carotid, the renal artery, the medium-sized artery in the body. And it's, of course, it is the most often seen in the arteries leading to the kidneys and brain. It also can affect the arteries of the legs, the heart, and really the arms. So I think this is one, and I think we look for treatments are available to control the symptoms and help prevent complications like a stroke. But actually, there is no cure for fibromuscular dysplasia. And as far as I know, and I think if the arteries in the kidneys are affected, the common symptoms will be high blood pressure. And this is really very important. And I tell you, if the arteries affected supply the blood to the brain, symptoms might include headache. And you have stated that headache was one of the complaints of this patient. So if you have both the hypertension and the headache, maybe it's one of the symptoms of fibromuscular dysplasia. Other symptoms like pulsing, feeling, or ringing in the sounds, tinnitus, for example, maybe a complaint of the patient, dizziness, sudden neck pains, stroke. She may present with stroke. So I do suppose that if you combine both headache and hypertension in a young lady, so they say headache, so the blood supply to the brain is affected. Symptom will be headache. If the blood supply to the kidney are affected, there will be hypertension. And I think that it could be a fibrovascular dysplasia in a young lady.
Okay. For me, I would have said A. I just can't get over the idea of pulseless young lady with the slight inflammatory syndrome, biological inflammatory syndrome.
Okay.
Yes.
So according to the ASIR criteria of classification of Takayushi's arteries, she had a positive diagnosis because she has only 27 years old, so she has one criteria. Codification of extremities. At the role play, she said that she has some weakness in her limbs. She had decreased brachial artery pulses. For the blood pressure difference, she hasn't a blood pressure difference. She has no root over the subclavian arteries. But on the renal ecography, I said there was some thickening in the abnormal aorta. So for the obligatory criterion, she has an age under of 40 with we will see after for the subclavian arteries, but on the examination, she hasn't radial pulses on bilateral radial pulses. She has a high ESR score, hypertension and aortic regurgitation in the echocardiography with pulmonary artery lesion. So she has a lot of criteria for Takayasu arteritis. Are you seeing my screen?
Yes, yes, I can see your screen.
Yes, yes.
Can I start?
Please do.
Okay. So, as we were discussing, according to the ASER criteria of the classification of Takayu's arteritis, she has more than 3 criteria on 6. So, each Takayasu disease. We will discuss the differential diagnosis, coarctation of the aorta, but she had normal pulses of lower limb with normal arch in TTE in the suprasternal view. For muscular dysplasia, it's likely, but we will complete by angio imagery. Hypertensive cardiopathy with undiagnosed monogenic disorder like said the European recommendation of hypertension, and Takayasu arteritis, it remains the most likely diagnosis for a 27-year-old female patient with unpumpable radial pulses and hypertension. So what is the best imagery to evaluate the disease activity, the Takayasu activity? MRI angiography of the aorta, invasive angiography, or ultrasonography?
Okay, pair share.
Do we mean the disease activity and then in the acute phase or the lesions that we already have?
For the activity, even the number of lesions are important. So for the number of lesions and the acute activity, because we will need it for the treatment. I will explain later.
Okay. For the lesions, I think it's invasive angiography. I think it's the gold standards. We've had some Takayasu patients before, and mainly women and mainly young women, and we've always had the diagnosis with invasive angiography, with the focal stenosis, arterial stenosis. Even if we will need stenting later, it would be better to have invasive angiography images. I think it's B. I'm not sure, but that's what I think.
Okay, but I have to remind you that she is 27 years old, and usually we need to repeat the imageries for follow-up. So we have to have a first imagery to compare it with the other ones.
A reference imagery, that's
Yes.
what you mean. Maybe the MRI then. I'm not sure. I'm just trying to. trying to speculate.
Okay. And for a Yemeni group, what do you think?
What do you think? Hey,
Okay.
am I right?
So yes, it's A. For the number of lesions, we can use invasive angiography, MRI angiography, or tomodensitometry angiography. But the MRI is one of the methods used most often to evaluate the Takayasu arteritis because it offers a reproducibility and excellent luminography and with a lack of radiation. I have to remind you that she is only 27 and she wants to have kids. So the utility of this non-invasive technique is particularly high in pediatric patients for whom biological costs and complications of angiography are potentially greater than for adults. So we proceed with an MRI angiography of the aorta, which showed thickening of the aortic arch, thickening of the abdominal aorta, of the walls of right and left subclavian arteries, and thickening of the left renal artery. So according to the physical exam, the lab test, and the imagery, what would be the best treatment choice? Prednisolone plus methotrexate, it's immunosuppressive therapy, prednisolone alone, or immunosuppressive therapy alone.
The slide stops. Oh. The slide stuck still in the previous slide, not moving.
And now?
Yes, it's moving. It's moving.
It was not moving. Still in magnetic resonance imaging. That's it.
Okay. For me, it's moving.
Is it moving now?
No.
Okay, I will restart. And now? Are you seeing my screen?
No, it's still not moving.
It's moving with me.
But I unshared
What would
and
be the best
reshared.
choice?
It's moving for me. I'm not sure if do you have any internet problems? Connection?
Now it's moving. It's moving.
Okay. So I was asking about the best choice of treatment. Is it corticosteroid plus immunosuppressive therapy, corticosteroids alone, or immunosuppressive therapy alone?
I'm not sure, but when I remember that when we had some Takayasu patients, I'm not sure, but I remember that the internal medicine specialist said if I'm right, that we give corticosteroids first, and if it doesn't work or if the response is not enough, we add methotrexate. So maybe prednisolone as a first line. Not sure, but that's what I remember.
Okay. And for the Yemeni group?
Prednisolone. B.
What?
A.
Both therapy?
A.
Okay.
Yes.
So it's right because according to the 2021 American College of Rheumatology, for the recommendation of vascularities and Takayasu arteritis, they recommend for patients with active Takayasu disease, they conditionally recommend the use of a non-glucocorticoid immunosuppressive agent plus glucocorticoid over glucocorticoids alone. And they usually use methotrexate. They also recommend this therapy for patients with Takayasu disease and renal vascular hypertension and renal artery stenosis. And it's the case of our patient. They also don't recommend surgical intervention for the artery stenosis usually. So this is the ring of the recommendation. I think it's really interesting to check it because usually we are in front of patients who has stenosis of arteries, and we have to know that the American College of Rheumatology insists that we have to start with glucocorticoid therapy plus immunosuppressive therapy.
All right. And start. Did we watch the rest of the video? Dr. Jamila is back. Hi.
The presentation is clear for you?
No, we don't see your screen.
Okay, wait. And now?
We see you.
دايماً نفس المشكلة.
You look beautiful.
Thank you. And now?
Yes, we see it.
And now it's moving.
Yes, yes. Clear. Patient profile. Age 27. Gender female.
Our patient has 27 years old, female, married, has no special habits. My screen is moving.
No.
She's presented with shortness of breath since 2 days.
Can you click on the slide? Yes. We'll play the rest of the video for the counseling.
Okay.
It's called Takayasu arteritis. It's an inflammatory disease that affects the median arteries, and after the MRI MRI we did, we confirmed the diagnosis. And we think that you have secondary hypertension due to stenosis of the artery of your left kidney. So this is why you have to take medications either for hypertension or for your inflammatory disease. You are going to receive corticosteroids daily and medications called immunosuppressive therapy once weekly, plus the antihypertensive treatment. We have to follow you every 3 months to start, and you're going to do follow-up imagery also. We are going to collaborate with an internist specialist, and he is more specialized on your disease. So I will follow you for your heart disease and your hypertension, and my colleague will follow you for your inflammatory disease, because we think that the Takayasu arteritis is the etiology of your hypertension, which affected your heart and caused your short of breath. You have what we call heart failure with preserved ejection fraction. You don't have to worry about it, because I think that after good medical therapy and after good follow-up, you will have free symptoms بإذن الله. So we have some questions.
Yeah, you told me this is a chronic illness.
Yes.
For how long I should use this medication, doctor?
So honestly, it will be a long-term therapy because it's a chronic disease, and we have to take the medications so we can stop the activity of the inflammation in your arteries. So this is why I think it should be for a long term.
Okay, what's about the pregnancy? I hope to be a mother. How to deal with this problem?
I don't think that it will affect your abilities to have a pregnancy. And for your hypertension, I will prescribe you a treatment that cannot affect your pregnancy or your abilities. You will receive a monotherapy that women can have when they want to have pregnancy.
Okay, doctor. What's about the other systems in my body? It will be affected, or what? Other system, other organs, as this disease affecting the arteries. What's about other systems?
According to the MRI that we did, you don't have other arteries affected that may affect other systems. And you hope that when you are going to take your medication, there won't be another system affection, inshallah.
Inshallah. Okay, what's about the surgical? Is there any surgical intervention instead of medication, medical treatment can be used in this disease?
No. No. In the case of your disease, we don't recommend surgical therapy, even for the arteries that are thickening. We think that with medical therapy, we will be able to stop the activity of the disease.
Okay, thank you. Thank you for your justification. If I have any question, can I call you at any time?
Yes, of course. I will be available at any time. We are going to have some resume card of your disease at the discharge. And you follow you every 3 months to start, and then every 6 months. We are going to do MRIs every 6 months at the beginning, and then one time per year. And we hope that everything will be okay.
Okay, thank you very much.
Thank you. You're welcome.
All right. Any comments? Rania, Dr. Jamila, where are you? Any comments?
Yes. Yes, maybe just one comment. Maybe I don't know. I think I just I demand if there are any other lesion or cardiac involvement during Tayashu arteritis, because we know that generally it affects the large artery, also I think coronary, and even valve lesion. So I don't know, Noor, can you answer if we should
Yes,
yes,
for
search
this,
for other cardiac lesion.
yes, for this
RPM
patient, he had a mild aortic regurgitation, and it's common and it's a minor criteria of the disease, but it was mild, modéré en français.
Did you think about coronary arteries?
Uh,
Is there any recommendation or guidelines to do, for example, CT scan, or should we
no,
search for
yes,
coronary arteries?
for the American College of Arteriology, they don't recommend systematic imaging of the coronary arteries if the patient is asymptomatic. But I saw, I have a patient that consulted to the emergency department with a non-STEMI diagnosis, and she was already known of having Takayasu disease, and we found a left anterior ventricular stenosis of the coronary left anterior ventricular stenosis. We proceeded with PCI, but she complicated with stent thrombosis, and she yes. And the patient had a cardiac arrest, and we couldn't solve him. She was about 50 years old, and she was followed up for Takayasu disease since at least 15 years. This is the second patient that I know and that I had in my quotidian practice. I was in front of two cases of Takayasu, this one and the other one of the coronary artery stenosis.
I think your answer, Noor, is that when we don't have symptoms, we don't go looking
Yes,
for coronary stenosis unless we don't
we
have.
don't go for it if the patient is symptom free. But I mentioned that there is coronary stenosis is not common, but we can see it.
Could be seen. It could be
Yes.
seen. We won't systematically look for it.
For the valvular heart disease, Noor, I think you can get both stenosis and regurgitation at the same time. For the regurgitation for this patient, what was the mechanism? It was the dilatation of the aorta, or really valvular disease?
No, it
Because
was.
I think there are some cases in literature which talks about describe it aortic valve stenosis, mitral valve stenosis. I don't know if it is mitral or if it is stenosis or regurgitation.
It's regurgitation by a valvular involvement, by the inflammatory.
I think most of the time in Takayasu disease, it's the aortitis. Whenever we have an aortic regurgitation, but maybe I don't know. The mechanism was obvious because it's really mild. Was there valvular thickening or? So it wasn't the aorta in your case.
No,
Aorta
it wasn't
was
the
enlarged.
aorta.
There was a dilatation of the aortic root?
No.
Okay.
I love this discussion, and I'm having you with us, Dr. Aranya. It's great. I love this discussion. I'm just one
Yes.
comment. I love the way that
We are
they
learning
asked
from
how
them.
long. I love the way that you asked about how long it takes with the methotrexate. I love the way that you asked about the pregnancy and other systems, and surgical. I would have liked to hear something, if you could counsel her on the side effects of methotrexate and what she should be eating and the
Yes.
diet. She should be getting some sunshine.
All right.
Okay, so a little more counseling with the patient, but it was beautiful. And Dr. Rania, صراحة قامت بالواجب. She did.
Thank you.
Okay.
Her shortness of breath is started gradual in onset, progressive in course, associated with orthopnea, BND, dizziness, and chronic headache. Past history, she has a hypertension since 1 year. 1 year. The only risk factor she has it is hypertension. During examination, the patient was conscious, alert, oriented to time, place, and persons. Febrile, no lymphadenopathy with the body mass index 24. Vital sign when we receive the patient, when the patient is received, blood pressure 180 over 95, heart rate was 110, temperature 38.2, respiratory rate 24, saturation 91. There is impalpable radial and brachial pulses. The clinical examination of patient mostly the head and neck and jugular was normal. Just there is a bilateral basal crackle. The heart, there is a regular heart sound, no added sound. Abdomen was soft, no organomegaly. Regarding CNS, also there is no focal lesion. Regarding laboratory investigation, hemoglobin level was 11, ESR 40. Normal renal function with normal GFR. The troponin was 8.6 picogram per ml. YBC 160. CRP 24 and potassium level was 4.1. Calcium 2.3 and normal thyroid function test. And the N-terminal pro-PMB was 3,000, sorry. The ECG of patient shows a sinus tachycardia with sign of left ventricular hypertrophy, and the echocardiogram shows the left ventricular hypertrophy with preserved ejection fraction, impaired diastolic function, and mild aortic regurgitation, and with pulmonary arterial systolic pressure 38. When we do MRI angiography for aorta done, it shows thickening of the aortic arch, thickening of the wall of right and left subclavian arteries, and thickening of the left renal artery. Our differential diagnosis, Takayasu arteritis, coarctation of aorta, viromyocarditis, cardiomyopathy secondary to severe hypertension, and fibromuscular dysplasia. Our final diagnosis, it is heart failure with preserved ejection fraction precipitated by uncontrolled hypertension, which is secondary to Takayasu arteritis. We start treatment with the oxygen therapy, intravenous diuretics, intravenous nicardipine in ER, prednisolone 1 milligram per kg per day, and methotrexate 10 milligram per week. And when we follow patient after 4 hours, patient was evaluated. Her vital signs were stabilized, saturation increased to 94, heart rate become 90 beat per minute, and blood pressure 140 over 80. After 6 months, patient was totally free and of symptoms and dramatically responds to therapy. So this case demonstrates a rare case of Takayasu arteritis in young female with congestive heart failure as predominant manifestation. The heart failure was precipitated dominantly by the secondary hypertension. There is no difference in management of congestive heart failure in patients with Takayasu arteritis. Optimized anti-failure therapy with combination of steroids and methotrexate successfully induced remission. Thank you.
Okay, thank you for that. Dr. Rania, do you have any comments?
No, I am just trying to connect with the PC. I congratulate the two trainees for this very interesting case, but I just have some question. Why did you not think about fibrodysplasia? It's a female. This is a female, young age, maybe problem in the renal artery, hypertension. You did not perform the other imaging testing on the carotid of the lab. I don't know.
during examination, Dr. Noor examine her and find that there is an equal or absence radial and brachial pulses, and she collect criteria for the Takayasu, and she meets, I think, most probably go with Takayasu, as Dr. Noor sent the case.
Yes.
But considering
We
Yes.
thought about myodysplasia, of course, Dr. Rania, but for the angio MRI, we showed the carotids. They were normal. She had just stenosis of the subclavian arteries. And as we say in Tunisia, les jeunes femmes sans pouls. Generally, it's Takayasu disease, because she is a 27 years old female patient with null pulses in the upper limbs. Even for the TTE, aortic regurgitation, she had a mild aortic regurgitation, and the aortic regurgitation is a minor criteria of Takayasu disease. So she was young. She had subclavian stenosis, no pulse in the radial, bilateral radial arteries, aortic regurgitation, hypertension secondary to renal stenosis. All these criteria are in favor of Takayasu disease. But yes, our second diagnosis was certainly the fibromuscular dysplasia, and we put it in the differential diagnosis.
Yes, did you perform an imaging of the lower limb of femoral, iliac, and the knee, the other vascular axis of the lower extremities?
No, the MRI just stopped in the pelvian à l'étage pelvien. Je sais pas comment dire ça. We performed an angio MRI of the aorta, and we just saw the iliac arteries, and they were normal. And in the examination, the pulses of the hour limb were present and positive. So we didn't perform any other imagery.
I think the MRI imagery was quite in favor of the Takayasu, because usually in the fibromuscular dysplasia, we have the string of beads aspect, like dilation, stenosis, les aspects en chapelet. So I think the MRI makes us evoke more the Takayasu syndrome rather than the fibromuscular dysplasia.
Okay.
Should I play the video now?
And what about
Okay, sorry.
the treatment? What about the treatment of this patient? Did you start corticoid or what?
Yes, we started the prednisolone with a high dose prednisolone, 1 milligram per kilogram per day, methotrexate weekly, amlodipine for her hypertension, and dapagliflozin for the heart failure with the preserved ejection fraction. At the appointment of 3 months, she was totally free symptoms, and at the 6 months we will recommend another angio MRI to verify the remission of the disease.
Did you discuss the eventuality of percutaneous treatment of the renal artery stenosis?
No, because according to the 2021 American College of Rheumatology, they don't recommend any interventional or surgical treatment for those patients. They initially prescribe or recommend medical therapy And
Even for
then,
the upper limbs, or only for the renal artery? Even for the upper limbs, because we
for
tend to
all,
see
for all, yes, yes, for
a lot of
yes, for
stenting
all,
of the upper limb.
yes, for all the stenosis and
All the arteries.
all the arteries. I showed you the link of the recommendation, and they insist that they don't go for a surgical or an interventional treatment. They wait for the medical response.
Okay.
We
And
tend
how
to
long?
see.
Yes,
Alice,
yes, Emma. It's up to you. No, it's up to you.
Thank you. We tend to see a lot of subclavian PCIs because it's the other way around. Where they do the PCI and then we discover the Takayashu when they have a coronary stenosis. That's why we see a lot of them.
Yes, this was my question, because usually, as I am interventionist, maybe there is a key message in this case that when we discover subclavian stenosis in a young female, we should not
Don't
go
explore it.
directly to the
We don't
PCI,
investigate.
should not directly go to the interventional treatment. We should investigate and think about Takayashu and start with a medical treatment. And if the patient will get a positive answer to the treatment, to the medical treatment, we will not do PCI anymore. That's a very good key message for this case. From this case, we learned today. Yes. And did you perform the evaluation of this patient or not yet?
Yes.
Not
This
yet.
is Jamila Nas.
Not yet.
Yes, it's a fascinating case. I really appreciated the analysis of the case, and we've learned a lot from the case actually. And it's, a case which gives you a lot of messages. Thank you very, very much to Professor Mona and your kind colleagues from everywhere.
Just another question, Noor.
Yes.
Another question about the medical treatment of hypertension in the case of Takayashu disease. Did you perform a biography about this special case? Is there any molecular drugs to recommend?
No,
I don't think so.
According to the recommendation of American College of Arteritis, they don't recommend any special treatment for hypertension for Takayashu disease. It's the same treatment for all hypertensive patients.
Was it well controlled with only amlodipine, because she would be taking corticosteroids, and I'm not sure if a monotherapy, I know she's a young female, but I'm not sure if monotherapy is enough. Was she well controlled by amlodipine alone?
Yes, she has 14
but maybe there is some,
but we didn't think about adding any other treatment, because we think that the glucocorticoid will control or stop the stenosis of the arterites, and inflammatory the inflammation of the artery have also I'm sorry, I don't use English usually.
We don't speak French. Okay.
I think there is a place. There is a place for methotrexate, azathioprine, other drugs. I think anti-inflammatory to treat the Takayasu arthritis. I think so. There is a place for some drugs like anti-inflammatory drugs, maybe methotrexate, maybe azathioprine, maybe
yes,
I think.
Yes, she was prescribed prednisolone and methotrexate, and this is the point. I think that anti-inflammatory drugs will help us to control the hypertension, Dr. This is why I put her only in monotherapy. And
but I think the corticosteroids are the mainstay of therapy for active Takayasu arthritis. I think so. Yeah, this is the mainstay of therapy, along with some cytotoxic drugs to achieve the remission and tapering of long-term corticosteroids treatment, as far as I know. It's a very interesting case, and thank you very much. You've learned a lot, and we gained a lot from this nice case.
Okay.
Thank you.
And I think
one other question, because
I think there is a very interesting point that the Takaysu arthritis is also known as pulseless disease, occlusive aortopathy. I think there are many other names for this.
Okay. Should we go to the debriefing? Going to share my screen. You can see my screen, right? Okay, let's get on to the debriefing part. So, okay, case 21. Okay, let's quickly run through this. Warmly greeted the patient, displayed familiarity, primarily used open questions. Why did you get 2? Who gave them 2? And why? I think we lost Yemen. Yemen, are you here? It's just us. Who gave you 2? Why? Amna, you're the only one here. Did you give them 2?
I don't think it's
Hello, Yemen.
these are the ones where we don't put numbers, we just tick the,
Okay. Was there any?
Yeah, so I guess two
for-
people clicked on it and one person didn't. I think that's it. It's not a number, not 2 on 5.
Do you think they covered the patient's concerns?
Yes, yes, I do, because she asked about pregnancy, and about further treatment plans. I think they did.
Dr. Rania, what do you think? Someone gave them a 3. It's rising. Do you think they covered the patient's concerns?
Yes.
Yes.
Mostly.
Yes.
I think she just the work, if she can go to work, and the exercise and the diet, and if there's any interaction with methotrexate and other drugs, that could have been covered a little more. Okay. Liz asked about patients' understanding of the problem. You're giving her 3. Why? Who did this? Yaman, you did this. Yaman,
No,
that wasn't you. What did she get 3 here?
maybe someone didn't pick
Four.
Yeah, I think it's because we tick. We don't give. This is not where we give. Where we give.
the screen. Okay. Hello,
Yes.
everybody. My talk will be about phytoimmune modulators. A stronger immune system, as we know, is essential for good health, balancing the ability to fight infection while preventing allergies and autoimmune disease. However, improper immune response can lead to chronic inflammation, condition, and allergies and autoimmune diseases. The main action of immune drugs or immunomodulators are immunostimulants, immunosuppressant, and immunoadjuvant. But are often toxic and can have adverse effects. This has led to increased interest in herbal remedies that can safely modulate the immune system. So phytochemicals from herbs such as alkaloids and flavonoids have shown immune-stimulating properties without significant side effects associated with synthetic drugs. So phytochemicals are naturally occurring compounds in plants, often referred to as secondary metabolites. The term phyto comes from a Greek word for plants. With over 4,000 discovered phytochemicals, this compound plays a crucial role for not only in plant defense, but also in human health, offering potential therapeutic benefits. Their classification based on molecular weight and function aids in understanding their
diverse role in both ecology and medicine. There are many classes of phytochemicals such as alkaloids, flavonoids, polysaccharides, phenols, and tannins. And they have many roles in plants, such as secondary metabolites, defense mechanisms, and aesthetic qualities. They contribute to plants' color, aroma, and flavors. And phytochemicals' therapeutic potential possess various health benefits, including antioxidant properties, anti-diabetic effect, memory enhancement, cholesterol lowering, adaptogenic properties, anti-cancer activities, and immunomodularity effect. Starting with the first class, which is alkaloids, are indeed a fascinating and important class of compound derived from plants. They play a significant role in medicine due to their various therapeutic properties. They are a nitrogen containing compounds that are typically structured in cycle forms, and they are about 5,000 known alkaloids, making them a largest class of secondary metabolites in the plants. Notable alkaloids include nicotine, found in tobacco. It has a stimulant effect. Cocaine, a powerful stimulant and anesthetic. Morphine and codeine, used in pain relief. Quinine, traditional use to treat malaria, and reserpine, used in treating hypertension and mental disorder. Regarding therapeutic uses, they have an anti-tumor activity, antimicrobial properties, analgesic effect, and immunostimulation. So many alkaloids are being researched for their ability to enhance immune responses. The second class, which is polysaccharides, these botanical polysaccharides are complex carbohydrates found in plants known for their diverse structure and function. They exhibit various health benefits, including anti-inflammatory, antioxidant, and immunomodulatory effect. Regarding the immune modulation and innate immunity, particularly through the activation and regulation of macrophage activity, it's a key mechanism by which polysaccharides exert their therapeutic effects. Due to their ability to modulate the immune system, polysaccharides could be beneficial in treating various conditions, including infection, autoimmune disease, and cancer. Glycosides are an important class of compounds in pharmacology and biochemistry. They characterized by their polar nature due to the presence of sugar. They classified to multiple subclasses, and they have a variety of pharmacological importance in cardiac systems. Certain glycosides, such as cardiac glycosides, which is we will know about digoxin, which are used in treat heart condition by increasing their force of heart. Also in central nervous system, some glycosides can stimulate the central nervous system, impacting mood and cognitive function. And also immune system, they may enhance immune response, contributing to overall health. And finally, antimicrobial activities. Another class of phytochemicals, which is phenolic compounds, they are characterized by presence of aromatic ring with one or more hydroxyl groups. They have an antimicrobial properties, and they are potentially toxicity, while beneficial. Some phenolic compounds can be toxic to certain organisms, including pathogens. And now coming to the flavonoids, which are among the most widely distributed natural products in the plant kingdom, found both in their free and form and as a glycoside. They are primary water-soluble compounds. Flavonoids have an antioxidant properties, which is potent antioxidant and free radicals scavengers, helping in prevent oxidative damage to the cell, and also strong anti-cancer properties by inhibiting the initiation, promotion, and progression of the tumor. They protect against various stages of carcinogenesis, making them a focus for cancer researchers. Regarding the cardiovascular, they reduce the risk of heart diseases, contributing to overall cardiovascular health, and they are using as dietary supplement for cancer patients. Anthocyanins, which are a colorful pigment found in various fruits, vegetables, and flowers, contributing to their red-purple colors. They have many health benefits. They may help to protect against DNA cleavage, reducing the risk of genetic damage. also influence estrogen activity, potentially altering development of hormone-dependent diseases. And they have an enzyme inhibition, which may have therapeutic implication, and they pose the production of cytokinase, which play a crucial role in regulating immune system. They also has anti-inflammatory effect and lipid peroxidation prevention, and they also can they may decrease capillary permeability and fragility, enhancing vascular health, and they also can contribute to the strengthening of cell membranes, improving cellular integrity. Coming now to the tannins, which are amorphous water and alcohol-soluble substance known for their bitter taste. They are a complex phenolic compound, and they classify to many classification. And but regarding their physiological activities, tannins can enhance the activity of phagocyte cells, which are crucial for the immune response. And also, they may play a role in modulating tumor activity within the host. Also, they have an anti-infective action, contributing to their use of traditional medicine in potential therapeutic application. Saponins, which are a naturally occurring compound commonly found in various higher plants, particularly in roots, tubers, leaves, flowers, and seeds. And they are also can be classified based on carbon skeletons or glycan structure. Regarding their biological activity, they have an anti-tumor effect. They possess anti-tumor properties against various cancer cells. Several supplements inhibit tumor cell growth through mechanisms such as cell cycle arrest and apoptosis. And now coming to the terpenoids, which are natural products composed of isoprene units. They are classified based on the number of isoprene units in their structure. Regarding their biological activities, they have immunological effects, appear to be mediated by immunological process influencing the immune system in two ways. First, by enhancing antibody production, and second, by suppressing T cell response. They may also suppress T cell response, which can be beneficial in certain inflammatory condition. They also has an anti-inflammatory properties. Coming to the sterol, which is the last class, they are a subgroup of sterol that include compounds found in plants. And also there is in animals, which is cholesterol. They have a cytotoxic activity. A mixture of sterol and the sterolene has been shown to enhance the cytotoxic ability of natural killer cells against NK 562 target cell line, indicating potential role in immune defense. And they also have, they suggest that the sterol, a specific ratio can help restore the balance between T helper and T helper 1 and T helper 2 cells. This balance is crucial for determining the outcome of immune response, influencing both pro-inflammatory and anti-inflammatory pathways. And the effectiveness that this enhance occurs as extremely low concentration, highlighting the potency of phytosterol in modulating immune response. And thank you.
Okay, thank you. I would have liked to have some examples. That was very nice. It was very nice and very informative and very summarizing for everything. But it would have been nice to have some examples. Like
I tried to make an example for every.
It was very nice.
It's a big
and I like your PowerPoint
subject.
presentations are looking much better. It was very nice. Okay, who has the second case? Dr. Rania, do you have anything to comment? Do you have any comments, Dr. Rania?
No.
Okay, second case, please.
Just I have one question. Yes, no comments. It was very good. Congratulations. It's a very interesting topic, and I learned many things.
It is. It was very informative.